Welcome everyone, and thank you for joining us for our session today, Lessons Learned While COVID-19 Class is Still in Session. Joining our discussion today, we have Skip Rollins, CIO from Freeman Health.
Good morning, Jeff. I wanted to talk real briefly about Freeman. We are a 4-hospital rural healthcare system, but we're also an active independent medical center. And we're currently a Meditech customer on our inpatient side and a customer on in our clinics.
Also joining our discussion today is Linda Stevenson, CIO at Fisher Titus.
Hello, Fisher Titus in Northwest Ohio. We're a rural hospital, about 100 beds. We also have around 23 locations of physician offices. We have our own nursing facility, assisted living, transitional care unit. We also own an EMS and transport unit. So small hospital, but big footprint.
Thank you, Linda. Also joining our discussion today is James Reed, CIO at Conway Regional Health System.
Yeah, thanks, Jeff. Conway Regional Health System is a 150-bed community-based hospital located in Conway, Arkansas. We have a rehabilitation hospital as well. And then we have several specialty and primary care clinics. We have about 80 employee physicians with us. We're a Meditech 6.1 shop. We're actually scheduled to move to Expanse in March, but we delayed that with the COVID pandemic. So we'll be looking forward to getting that going as soon as we can.
Thank you, sir. Also joining our call today is Dr. John Paul Jones, a practicing physician and former CMIO at Centra Health.
Hi, Jeff, and again, thank you for the invite. I'm calling from Centra Health. The Centra is located in Central Virginia. 4 hospitals, 60-plus ambulatory practices, about half primary, half specialty, 450 employed providers. We cover a footprint about 8,000 square miles, about the size of New Jersey.
Thank you, Dr. Jones. Also joining our call today, we have Joshua Tennant, the Orthopedic Service Line Director at Conway Regional Health System. Joshua?
Yeah, so like James, I also work at Conway Regional Health System. I oversee the orthopedic service line. We have 5 full-time orthopedic surgeons, 1 clinic orthopedic physician, 1 podiatrist, 3 PAs, 2 nurse practitioners. And we also have a fully functional therapy area in our clinic space as well. So I oversee operations at the clinic and all the orthopedic service line throughout the healthcare system.
Thank you, Joshua, and thank you for joining today. Skip, if you could, please share with us where Freeman Health was on their telehealth journey and what has changed in that journey while reacting to this pandemic.
Thanks, Jeff. Freeman currently and previously was a telehealth program. We have, as you know, being a rural healthcare system, we have some specialties that we just can't get folks to come here to do. So a lot of the telehealth that we're doing right now with high-risk pregnancies and school programs and things like that are because we don't necessarily have a specialist in that area. So we do that every day. We have contracts with virtually all the schools around us for telehealth, and then it's what we call IT-wise point-to-point telehealth, where the customer has to be in front of a fixed kiosk and the person on the other end is in front of a fixed device as well. And we do a lot of that kind of stuff. So what we've seen change in literally the last month was the need to be able to provide telehealth for the physician or someone in the physician's offices in our clinics, was able to reach out to the patient, schedule a time, and have that patient visit with a physician virtually rather than face-to-face. And we went from 0 to first week we did 67. The second week we did a little over 200. Last week we did over 800, and we're going to be close to 1,000 visits this week. So we've had to learn on the fly. It's been very, very quick. We've had to learn a lot about the workflows in the offices, and we've tried to help them to understand a workflow with a telehealth visit that's a little more standard, so we have a consistent model. We've worked real hard to adapt our infrastructure to do it, and so it's really been an exercise of taking a tool that was what we chose was what we call a zero footprint tool, where there's no app for the patient, there's no app for the physician. They just have to get on the internet, and everything kind of lives on the internet. And that certainly expedited our ability to deploy the tool. And then the other part has been just working through the revenue cycle implications, working through the workflows, the documentation in the EMRs, and so that all has been very, very rushed on. It's all things that we wanted to do. It's all things that we thought we would do at some point in time. We just didn't expect to do it in a 3-week period. So it's really been interesting, and I would say that the blessing for us was that we had heavily invested in our infrastructure, and we were in a position where just turn things on that unfortunately a lot of people are not always able to do. So that part of it has been really good. And now we're learning how to do it on the inpatient side. We have and it's a totally different workflow, totally different challenges. And I think that's the one that's going to be more challenging because each specialty has a different way they do things, and it's really challenging us to do it in a consistent manner. But as I said, it's something that normally takes a year. We've done it in a few weeks, and I'm sure everyone else is dealing with the same problems. I would say that you got to have some standards, and you got to stick with them because it's difficult to afford to sustain if you don't.
Thank you, Skip. So, Dr. Jones, as a practicing clinician, how has your communication with patients changed since late January? What do you see as some of the advantages of utilizing the telehealth capabilities, and what do you see as the drawbacks of these virtual visits?
Well, like a lot of health systems, there's been aspects of telehealth in one form or another for quite some time. It's been somewhat fragmented and very niche, whether it's for a neurology consult to initiate anticoagulants or not on a CVAs, whether it's for psych. Really, with the current crisis, has certainly accelerated the process. I mean, really lit it on fire. One of the memes that I saw that asked, what's been the major initiator of IT recently in your organization? Choice A, CEO, choice B, CIO, choice C, COVID. And COVID is the one that really had the check mark. It has really brought to the attention the benefits of a well-organized, robust, true telehealth from the, and I'll be speaking primarily from the primary care, urgent care kind of standpoint. That being said, one reason that it hadn't been fully initiated before is it ain't easy. It takes bandwidth. It takes training. It takes devices. It takes patients that are interested in having that virtual visit by a screen. Now, we at Centra, had a choice about 4 years ago to either build, buy, or turf telehealth as far as consults or primary care, urgent care. We decided to turf, i.e. that we bought in with American Well, rebranded it for 24/7, and it's really their providers that are providing the medical advice. The medical advice, the treatment does not end up in at the time, EHRs that we had. And so Centra just got a little bit of cut of the action, but none of the real benefits. Now, we are using that same platform and piloted last Friday with my practice and a psychiatric practice, and continue to roll out this week. And we've had a good buy-in as far as providers as well as patients, but there is definitely some growing pains when you're doing it yourself.
Thank you, Dr. Jones. So James, as CIO, what strains have you seen on the health system's infrastructure, and what has been some of the major challenges for you and your department responding to the needs of the organization during this pandemic?
Yeah, thanks, Jeff. I think that's a good question. I mean, for us, the biggest strain that we saw, other than what some of the other panelists have mentioned was our work from home. So the pain point for us was we only have about 20 individuals that are working from home across an organization that's about 1,500 FTEs. When COVID became predominant in our area, one of the things we want to do as a health system is, obviously we're preaching social distancing for our patients and our caregivers, so we wanted to practice that with our employee workforce as well. And so there was a lot of the back office IT revenue cycle that we needed to move off campus and move back to their home offices so that we could continue working and continue doing the functions that we needed them to do. So we went from about 20 FTEs working from home to about 120 FTEs in about 2 weeks. And so the strain obviously was heavy on the IT department. They rose the challenge, of course, but just procuring devices, web cameras, laptops. I mean, some of these individuals didn't have that. We were fortunate that we had a decent stock, but getting those items right now, as some as you probably know, is a challenge. They're behind on delivery. So fortunately, we were able to get that. I think in some of the lessons that we learned in that deployment was it's not a one size fits all, at least not for our workforce. You have different generational gaps, and based off their workflow, what do they need access to? We use a VMware shop here, and so we use VMware to deploy our Meditech environment through a web-based application that worked for probably 75% of our individuals that needed to. Some have specialty applications they needed to use, so they needed like a laptop that was set up specifically for them. And so some of the solutions that we put in, again, VMware, deployment of virtual environments, and I was really proud of the team and how they were able to do that in a very short time frame. So.
Thank you, James. So, Linda, as your organization manages to the challenges of COVID-19, are you seeing additional requests for data and/or additional requests for the need to analyze that data to help provide information to the hospital leadership, clinical areas, supply chain, resource management, so they can make informed decisions quickly?
Absolutely. We were lucky to have had already installed a system called Kaufman Hall for data warehousing, but it was just basic, financial monitoring. And the first thing we did when we stood up our ICS, our incident command structure, was, we need to monitor number of tested, number of confirmed, number of in-house, number of masks. All those things had to be monitored, and executives wanted it in one-stop shopping. So we started writing interfaces right away, getting all the data we needed out of the EMR, because not all of it went to those we didn't have the need for at the time. Stood up, I think within the first week, we stood up our COVID dashboard, which monitored all of those things and also overlaid it with the numbers from the state of Ohio. So we could be monitoring how we're trending with the state of Ohio. Predictive analytics isn't something we really got into, but it definitely was information that we just have on a 24/7 standing up in the front of the room in our command center, monitoring, and it refreshes every hour, monitoring all of that, monitoring our counts. Some of the counts had to be manual, but they're still fed into the system so we can monitor N95s and that usage. It's been important. It's been nice to see how quickly IT can turn things around. I think it's been a nice opportunity for everybody to see how IT is integral to everything that we've been doing for this pandemic, and see what they're made of. So it's been a great opportunity for us to shine in that way.
Yeah, as a follow-up to that, Linda, as we look at IT, there are typically a lot of projects that are out there that we're trying to get funded, and sometimes justifying that funding or showing the reason for that funding can be somewhat difficult. What have you seen, or what do you think is going to be on the other side of this from a justification perspective for some of those things? And what are some of those things that you wish you had been in the middle of or had been deployed that would have helped during this time?
Absolutely. Well, it's funny because I was very frustrated as a CIO seeing all the needs we had come through during this pandemic, going, well, yep, I had planned for that. I had already roadmapped all those things, but we were like 3 months too late. So we had to move everything up, like telehealth, for example, our infrastructure changes, as James mentioned earlier. First thing we did was make those changes. So we shifted those projects. And the good thing is it worked well because we also have the demand for it now. The demand wasn't there before. They didn't see the need. So it was us trying to push tools that we knew would be amazing and beneficial, But now it's a pull situation, which is a nice mode to be in. One of the things we're doing now is we're planning for a demobilization, or as we're calling it, remobilization, is now looking at those projects that hadn't started, that had to be pushed out, and go, let's totally reprioritize. The organization sees IT needs very differently now, whether it's bandwidth, core switches, or a telehealth solution. They're looking at that very differently. So we are taking the time now to say, okay, given where we're at now, what does the project roadmap look like, and try to restart some of those projects.
No, thank you, Linda. So Skip, back to you for a follow-up question related to what we're going through right now. As a CIO who has recently dealt with another disaster, right? Not to bring up bad memories, but what lessons, what have you seen? How have you been able to recover from that tragedy, the tornado that hit Joplin, and how do you see some of those lessons learned moving forward with your organization?
So one of the things that we learned in the original incident is how valuable an incident command can be, and having folks that are organized, and what you get from that is consistent communication and consistent message getting out to folks. And we've seen that in dealing with our vendors that honestly that don't know how to deal with things like that, how we get conflicting messages from them about, is it left or right or up or down, and so we really struggle with that. But our organization has incident command, and then we at IT has incident command, because if we have an outage or things like that, we start our own incident command, and we link to that other incident command system. So I would say that having those processes worked out and having rehearsed those, as we do annually, we have a full incident rehearsal every year, and we make sure that we understand what tools we need, who needs to be in the room, how we deploy our resources, how do we contact our outside folks and let them know what we're doing. In some cases, even how do you handle the news media, and what do we say to them when they come in the building. So I would say, the rehearsal of something like that is very, very important, because it may seem redundant, it may feel like a waste of time when you're doing it sometimes, but I can tell you that when the real thing happens, and you know where you're supposed to be, and you know who's supposed to be in the room, and you know who's going to be doing the different things, so you actually become very familiar with that. And strangely, we have in our required education that we have to do as leaders at Freeman every year, we have to do a whole incident command in service to make sure that we're up to speed on what we're doing and those kind of things. So that's not the glitzy stuff, and it's not, and it certainly can feel like it's boring, but having rehearsed that and being ready for that, and being able to know exactly where your books are and your phones are and who you need to contact and who's going to be the voice of what departments is critical. And I would say that if you don't do that now, you should get up to speed on it. There's plenty of documentation out there available, but it saves you when you're in the crisis mode and you're trying to deal with things and you're trying to make things efficient. And the only thing that we really did here that wasn't necessarily part of that plan was we built and opened several hotlines for the community, for the physicians, for our testing centers, where they could call in and get very, very consistent direction on how to do things and where they should be doing things, and answers for patients. We had a hotline for patients that had tested positive, what they should be doing. So I feel like that, that communication piece is absolutely life-saving when you know how to do it, and you can stand it up and be going in a matter of an hour or two, versus it taking days and people are running around and unfortunately giving conflicting answers to questions to our patients and or our customers in IT or our customers in the hospital as well.
Thank you, Skip. So Joshua, back to you. As the person primarily responsible for the operations of the orthopedic clinic at your hospital, what have been some of the most challenging things that you've had to deal with? And then also, what technologies have you been able to leverage to help bridge the gap for clinicians that still need to connect with patients and see them in some form of virtual visit?
All right. So to answer your question, the most challenging thing we've seen from an orthopedics group, orthopedics is a very physical service line. Our physicians like to touch the patients. kind of see the reactions that they have to certain things they're doing with them to make sure there's something really wrong. So we've been hesitant in the past, or the group's been hesitant in the past, to implement any type of telemedicine or telehealth within the service line. But with this whole situation, it's kind of forced us to step back and see how we could potentially utilize this. So the solution we've been using is DoxyMe, which is a pretty nice telemedicine solution. Basically, you set up the patient by getting their telephone information or their email information. It sends that patient a link that they can either click on their telephone or click on their computer. It asks if they can have access to the camera on their smartphone, and the visit starts up as simple as that. And we've been pretty impressed at how we've been able to see that patients from age 18 to 85 have been able to use this solution pretty easily. And we've figured out, our physicians don't typically like to see patients without being able to touch them, but what we've noticed is with these post-follow-up patients, or post-surgery follow-up patients, excuse me, we can have them move their arms up and down, bend their leg, and kind of have a good visual on these patients to see how they're doing post-surgery follow-up. And then we also serve, we live in Conway, Arkansas, but we also serve communities outside of Conway, counties outside of Conway, and we've realized this is actually a really good tool to screen patients before they drive all the way to the clinic to see if maybe what they're dealing with does require clinic, or if this is something we can take care of over a telemedicine solution. So it's been just a really eye-opening experience for us, and maybe helping us think outside the box a little more quickly than we wanted to, but it's been really good for us to kind of expedite some of the growth and the patient capacity that we can see here in the clinic and throughout the service line.
No, thank you for that, Josh. So, Linda, what are some of the things that your organization is doing to react that you feel is unique and or innovative during this time?
Well, unfortunately, as we talked about earlier, our telehealth project had not started yet. It was on the roadmap for about a month later, so we quickly adapted it. In 5 days, stood up what we call our hobo telehealth, and that really is just simply continue to document in the Cerner system, because we're a Cerner shop here, as you have before, at the same time grabbing an iPad and using our Microsoft Teams to set up that communication with the patient. They're using phone, of course, the patient portal, and our hobo telehealth. We also stood up a chatbot and a COVID screening using Amwell. Amwell was our solution selected for telehealth, so that's something that we're going to be going forward, kicking off actually in 2 weeks for the full integrated solution. But we had to do a lot of little things to kind of get through that and make sure that patients have what they need and can still be seen. The other thing we really did is, I think to Skip's point, is we stood up our ICS, our command center, right away. We knew this would be a communication challenge, and I went to my team and we set up an IT command center and said, nothing gets done unless it comes through this group, this COVID management team, whether it's command center or IT command, and nothing gets done with that. We took a look at priorities and said everything stops except for COVID work, unless of course something's broken. That I thought was really important to get our team really moving together, prioritizing well, and not overwhelmed, because we have thousands of outstanding requests. And if all that hung out there and I didn't say to them, don't worry about it, just worry about this COVID stuff, I think that went a long way. And my team worked better together in the last 3 months than I've ever seen them, because they had very clear direction and communication. So I was quite pleased with how it turned out, and interviews, one-on-ones right now are all showing that they're more thrilled with their job now than they were a couple months ago, which I was really surprised to see.
Thank you, Linda. So James, you mentioned earlier that you had a recent infrastructure upgrade, and now you can definitely justify that cost. What are other things that you and your organization had in place that have been extremely helpful during this time?
So thanks, Jeff. That infrastructure upgrade I mentioned earlier was big for us. It was a $3 million project that we kicked off about 2 years ago. It was everywhere from our core switches to fiber runs to our VMware VDI background. The other thing that we did a few years ago that have proved to be very valuable during this time is we partnered with a local IT company to take on our technical operations. And so we we outsource some of our technical operations to that company. They have a lot of experience with work from home and with deployment of some of these solutions that we've deployed recently during this COVID pandemic, which has proved very valuable. Nobody likes talking about outsourcing resources, but for us, it was the best. It was the best thing at the time, and it's really proven valuable during this time. They're able to scale up their workforce much more quickly than we could have internally. A pain point for us is we're about a 16 FTE department taking care of the health system, with about half of those FTEs being on the technical side. And so when you're talking about increasing your workforce from 20 to 120 at home, looking at deploying 80 different providers on telemedicine, which we had a very small telemedicine footprint until this. We needed to upscale our technical workforce, and so the solution to that was being able to lean on our partner, the company called Adaptio, to help us with that. So didn't have that in the cards 3 years ago when we partnered with them, but it proved very valuable during this time.
No, thank you, James. That's good stuff. And yeah, planning definitely shows itself during these times. Things that maybe we didn't know why we were doing them at the time or didn't see this coming, but this has really been, put a stress on things, and it's good to have those plans in place and able to adapt and overcome. So Dr. Jones, as the representative clinician in this group, what are some of the tools that you found that have been in place? That you mentioned, telehealth at some level had been in place at Centra for a period of time, but what are some of the things that you found that have been extremely helpful? And then what are some of the things that you know about that are out there that you wish were in place that would have been helpful to have?
Nothing like, never let a crisis go to waste, because it really kind of shines a light on things that are busted or broken, as well as illustrates some things that are working quite well. I will say our incident command system, what has been in place for other events in the past, has done a bang up job as far as managing this. As mentioned before, our telehealth was, although it's been around for a decade, it was pretty lame. And low utilization. So again, it has kind of really accelerated the need for that, and seen some of the weak links, whether it's VPN devices, training of providers, as well as receptivity as far as patients go. It's also allowed for innovation. As Josh had mentioned, there's been some aha moments to say, do I really need to have a patient come in? Can we do this evaluation? Because whether you're in a specialty practice or a primary practice, just simply transport. Not all of us are healthy. Not all of us are mobile, and not all of us have at the ready childcare. So that 10-minute, 15-minute, half an hour doctor's appointment can be a several hour or a full day event that takes some major management. Let's use this opportunity to kind of reevaluate the value to the patient, not just the provider. Certainly, having done, particularly for the last 4 weeks, a lot of telehealth. I much prefer laying eyes and hands and ears on my patients and having that interaction for a number of different reasons. It's a lot of communication occurs that is nonverbal. Certainly the physical exam aspect, and the other dirty little secret is that from a physician standpoint, an office visit is a whole lot faster. I walk in a room, the nurses already prep things, everything's familiar, I know where everything's at, and it's in, out, patient's happy, I'm happy, and I'm on to the next room. Telehealth takes a little bit more time for many of the cases, and time is something that is in short supply all over, but particularly as far as providers go.
Thank you, Dr. Jones. So Joshua, what are you seeing as things that, one, you would like to see become part of the new norm, and things that you feel are likely to become part of the new norm?
I really would like to see, with these patients that we perform surgery on, that you're pretty standard and, by the book outpatient surgeries that, these patients recover pretty quickly and we see them leave the OR, and, we have these post surgery follow-up visits that we can start to utilize as telemedicine to catch up with these patients, that we wouldn't need them to come back to the clinic, that we're utilizing our physician assistants, our nurse practitioners to do a lot more follow-ups with this solution. And then again, as we're trying to expand our reach as a service line to try to capture these areas outside of Conway, that we can utilize telemedicine for that as well long term. We've been trying to look at opportunities at these clinics that we have outside of Conway to set up some kind of presence at these primary care offices that we have. I think this is just another opportunity that we have to where maybe, we're at that primary care office once a month, but we're available for those clinics every day of the week or during clinic hours here with this telemedicine solution. So I think there's a lot of kind of forced innovation that we found with telemedicine that I think is really going to help us grow as a service line.
Thank you, Joshua. So as we kind of wrap up our time here, I did want to allow some time and just go around the horn and ask each one of you for some parting thoughts, some words of encouragement, whatever you'd like to share with our viewing audience as they view this roundtable discussion. So I'd like to start with Linda. Linda, what is something you'd like to share as kind of a parting thought?
So I think the one key thing that really isn't been brought to light in too many ways, and that is that IS had, we've been all part of the surge planning, the surge that we're all expecting, that thousands of patients or hundreds or whatever it is, and all of us focused on that. But what I try to remind our hospital is that IS had the surge before the surge. So we had all that work that they are going to receive when the patients show up. We had to do that much and more prior to. We worked, 7 days a week, many, many long hours, and did a bang up job. I was so impressed. But what that's done is changed, I think, the light that everybody is seeing IS in, that we are able to deliver, that we can be part of the solution. And I've been really, really happy with that as part of the senior leadership team and as part of IS. So that's one thing. The one takeaway I have is, and then also everything we go through, everything we discuss is part of a lessons learned and a future disaster recovery, like Skip said, and Dr. Jones said, we never waste a good disaster, right? So what do we learn from this? We write it down and it turns into a plan for the future. So it will not go to waste.
Thank you, Linda. Skip, what are some things you'd like to share as kind of parting thoughts?
Linda said one thing that really rung true with me, and that is our IT team stepped up. And a lot of times we toil away in the background. A lot of people don't really see what we do and how we can do things. And I think that, that is that credibility that we've got earned through this process, and by being able to them, it looks magical that we can pivot so quickly and do things, but we've all been successful because we planned, and we've worked in the background, and we've anticipated what the organization might do. So while the pat on the back is nice, but it's really the pat on the back is for things that we thought of and did long ago, and positioned ourselves. And the other thing I wanted to mention was, and when Josh was talking about the patient population and doxy, so one of the things that we've really started to take a hard look at after doing this for a few weeks is we still have a fairly good-sized population of people out there that for some reason are kind of adverse to using the telehealth solution. And we're investigating that. We're trying to look at what those reasons are. We're doing some analytics with some heat maps about geographic locations and communities and things like that to try to see how can we reach out to those people more effectively. And I've had some discussions with our CEO and talked about things like where we go to those population centers and we offer them a vehicle to do a visit with a physician, like a van or bus or something like that, or just see what we can do to get those people where they can have access to health care. And I don't believe it's just because they have a bad sales signal. I think there's a lot more to it than that. So as we investigate that and look at that, I think it will ultimately allow us to be closer with our patient population and also offer a better service to our customers if we understand what their obstacles are.
Thank you, Skip. So James, what are your parting thoughts?
Yeah, thanks, Jeff. I mean, similar to the comments that Linda and Skip have mentioned, IT has been involved in almost every aspect of this planning from our hospital standpoint. So it's been very gratifying to see that. Some of the things that, from a hospital standpoint, organization that I'd like to just mention, because I'm very proud of what we've done is, we haven't laid off any employees. We haven't furloughed any employees forcibly. We've been finding different job roles for people to fall into. When they tell us that we can't do elective surgery, we've got a whole pool of highly skilled individuals that can do something else for the organization, which we've done. And, on the flip side of that, IT's had to adapt and give different access to people, different job roles to people, set up different kind of, we've got a call center that we set up for the public and the physicians in our area to call if they have any questions that are staffed by nursing staff. We've got a patient liaison team now that's going into the rooms because we've got no visitors coming into the hospital. And so this patient liaison team is working with the physicians and the nurses on the staff on the units to communicate with the patients. And so IT's been involved in that. We've been deploying iPads and Doxy solutions for them to be able to communicate with their loved ones. So, we've done several things like that, as I'm sure other organizations have. But as Skip and Linda mentioned, it usually comes back to IT in some shape, form, or fashion. And that's been very gratifying to see how we can not only take care of the keeping the lights on, but then, really ramp up in this crisis and help our hospital maintain our positive atmosphere and in our culture and our environment and in our community. So that's been a big satisfier for me.
Thank you, James. So Joshua, what parting thoughts would you have for our viewers today?
So again, my biggest thing is that you really have to be careful about putting yourself in a box, and it shouldn't come to a crisis situation that kind of forces you to really think outside of the boxes that we put ourselves in. But you just need to be careful in the types of absolutes that you speak. Again, our providers thought it was kind of not realistic for us to use the telemedicine solution for the service line we were in, and we've just found that to be very not true. And we can still deliver high quality orthopedic care through a telemedicine service. As administrators, I think we're always trying to look at how we can maximize productivity, and we think we have an idea of what maximized productivity looks like. And what I found on my end is that this is a tool where we can continue to further maximize our productivity without putting an undue stress on our staff. It's a solution that's not going to add just a crazy amount of work for our folks here, and we found that our providers are actually pretty excited about this solution, and that they're finding themselves thinking of different ways they can practice their orthopedic care. So I think that's the biggest thing, is to just always be on the lookout for ways to innovate within your service line and just within your area in general. It's easy to kind of think that you've tapped out your resources, but what we found through this is that there's just so many opportunities that we just weren't really even thinking of.
Thank you, Joshua. So Dr. Jones, as we think about, things are starting to get back to normal, right? Or at some level starting to get back to normal. We're seeing the other side of the curve possibly, even though things are still very hectic and a lot of things are still going on in the world. What do you see as the new norm? Or what thoughts would you like to share around what you see as the new norm, or what we should do as we get back to normal?
Yeah, I hope that the new norm is an improved norm, that honestly, I really don't want to go back to where we were. For a couple of reasons. One is that support, whether it's IT or other resources, have been doing more with less, have had single points of failure, has had cutbacks in the face of increasing needs and complexity. So I hope that the new norm will be application of resources, attention, and scale. Oftentimes IT is hit with these ambitious projects, in which may not get fully deployed or fully supported or fully utilized. So one, I hope the new norm is not like the old norm. I use this as an opportunity to learn from when there are things broken, they need to be fixed, not just duct taped. The second is use this as an opportunity for innovation. Now I know, when the house is on fire, you don't go shopping at Consumer Reports for the best smoke detector, but you can see what's going on, and these lessons have real consequences. So let's use that. Let's try to capture where we can processes, protocols. They learn from when things don't work as well as when things are working well. So that can be replicated with the next crisis or crises. And although this was a novel a member of the coronavirus family, having something like this or different disaster disruptor occur, that's inevitable. That is going to happen. So let's learn from these lessons rather than having to kind of reinvent each and every time. Thanks.
Well, thank you, Dr. Jones. So some things that have been on my mind, and as a former hospital CIO, seeing the spotlight on IT is somewhat gratifying. Right? I know what you guys are going through on a daily basis, and I don't recall getting those phone calls from the CEO or the CMIO and saying, "Hey, my computer booted up fine this morning. I got all my reports I was looking for. Thanks a lot, IT team." That just doesn't happen. But it is really shining a light on how important technology is to today's healthcare delivery systems, and the reaction of the healthcare organizations and the IT staff of those healthcare organizations has been key to weathering the storm, for lack of a better term. But one of the things I'm focusing on or seeing from the industry is as we begin to recover, right? So as we look at things getting back to looking at the financial side of this. I mean, right now organizations are doing what they need to do to see patients, to take care of patients, to treat patients, to do what is needed to keep the population healthy. But there's going to come a time in the next month, 2 months, whenever it is, we're all going to have to take a look back and see what did we spend on this and how do we recoup whatever funding is available to us, from the federal government, from the state government, from health insurance payers. How do we go back and quantify the services we provided for these patients that were dealing with COVID-19, as well as going back and looking at the services and the procedures that were put on hold or held off until things get back to some level of normal. There's going to be, again, another large strain on not only the healthcare IT organizations of healthcare systems, but also on the revenue cycle teams, the admission staffs, those that check eligibility for insurance, things like that, as well as the billing staff, follow-up staff, making sure that appropriate coding is being done, making sure that appropriate billing is being done for these things that happen. And we here at ROI, we're hosting this roundtable discussion today to get your thoughts and share with other organizations what you people have been doing to weather this storm. And we just want to let everyone know who's listening that, we're here to help whatever way we can. We're not trying to sell anybody any services, but if there's a gap that needs to be filled, ROI provides services everywhere from project management as you look at new things coming out on the other side of COVID-19, revenue cycle, optimization services, billing and coding audits and things like that. So anything we can do to help going forward, help bridge this gap, help these organizations, survive through this time. We want you to know we're here to help, and whatever that means and however that looks, we're going to be very flexible and dynamic with the way we provide help to these organizations. But I would like to just, having said that, Skip, James, Linda, as you look at your organization going forward and what you're going to need to do, I know, James, you had to put your implementation of Meditech on hold for a period of time, and that'll be coming back around. But what do you see as some of the big challenges going forward, and as you look at helping these organizations, helping your revenue cycle teams bill and things like that? What do you see? So I'd like to start with James, and then we'll go to Skip and then Linda for just some final thoughts on that.
Yeah, I think that's a really great question that, to be honest with you, I probably haven't put enough thought in with our senior leadership team. We know there's going to be a lot of data requirements, to your point, Jeff, about tracking COVID-19 related expenses. And so we've already kind of started doing some of that on the front end. We've got organizations asking us for clinical data, like our Department of Health, some of our other organizations in the state, because, they're trying to track this from an epidemiological standpoint. So we've got probably, there's going to be a lot of report writing needs is something that I see, and extracting data out of our Meditech system. The revenue cycle is going to have to, once we start open up the floodgates, so to speak, with seeing surgical patients again. And I mean, we're going to want to turn those claims around as quickly as we can. I mean, our average AR days is about 50 right now, but that's going to increase as we start seeing more patient volume come back in. So be able to respond to that. But I think that the data requirements, and then the tracking of expenses and the tracking of manpower that we've dedicated to COVID-19 are going to be the biggest challenges that we're going to face, or opportunities for another round of IT showing what they can do here in the next several months, because I think there's going to be a lot of ask of that, not only from our hospital administration staff, but from government agencies and other healthcare entities. So.
Thank you, James. Skip?
Well, I mean, I would echo exactly what James said. I think that there's going to be a lot of people interested in the data that we've gathered, and we've already started to have requests from other organizations about sharing data and those kind of things. And I think that it kind of legitimizes some of the things that we've been talking about around data repositories and data warehouses and analytics, and our ability to respond to the questions like that is, once again, it's legitimized by a crisis of some kind. And so it's almost like when CMS pivots on us or someone like that, we always have to respond and react. And so I think that, that'll be one of the big things for sure. But the other thing that I wanted to mention is, and I'll speak about Freeman here in particular, and James and Linda, I'd be interested to hear your perspective, but the credibility that we've gained by being able to respond to this crisis positions us well to be more trusted advisors, if you will, and for IT to be considered more in business decisions. And I think that's probably the thing that I am most excited about, is that you have an opportunity to sit with the inner circle and talk about where the organization is going and how IT can facilitate a lot of things that they want to do. And we've certainly shown them that they can't do a lot of things without IT being part of it through this last few months. And I think the realization by some of the senior level executive folks how much they do depend on IT, and that realization coming to a lot of folks is certainly something that we should be smart about how we use that. But I think that having that credibility and seeing that IT is in fact a big part of the business and how it works is something that I feel confident that all of us will see in different forms, because we've kind of proven our worth, if you will, in the last few months. And unfortunately, too often they see us as a utility, and just make sure the light comes on when you flip the switch. And I think that a lot of folks have realized that IT is a lot more than that now.
Thank you, Skip, for those thoughts. Linda?
So I totally agree with what Skip just said. I want to add that I think there's quite an appetite for change now. Providers, clinicians, everybody's chomping at the bit they see what's possible with all the innovation and the regulations and the payment models. So the next chunk of work for me is to make sure I manage that. Number one, we got to get out of crisis mode. Changes coming fast and furious. We need to get back to a more organized testing and production change control process so that our products are always good, because if we continue this mode, that won't be the case. Also look at financially. We've all hit a big hit financially with elective surgeries canceled and everything else that's been going on. We have to stop and reevaluate where is our dollars going, or look at our capital investments for this year. Are we putting our money where we really need to be putting it? So, and I'm lucky in that we do have a seat at the table and have had for a while with IS part of the planning, but certainly I think to Skip's point that we are a much more aligned and trusted advisors than we ever have been. So looking at the capital, making prioritization decisions with them, and getting change management back in place so that we are all working at a good pace, at a pace that we can keep up with, and that the products we turn out are good. Because I'll be honest with you, the stuff we did in 5 days wasn't the best products we've ever put out. We did what we had to do to make sure the patients were seen. So we want to get back to delivering the way we should be delivering.
Thank you, Linda. Dr. Jones, you've always been a very technology-focused physician, right? You've been CMIO at a large system there, Central Health. What has this done to help you focus or justify your interest in technology over the years as a physician?
You know, it's underscored what the primary goal is. The primary goal is to provide care for patients. Although I appreciate what Linda was saying as far as putting things out and maybe not be the same quality because of the time, sometimes we overthink it. Yeah, sometimes we aim for perfection and don't aim for utilization, accountability, usability. That is really the end game. And so I'm seeing a reframing of implementation and support, whether it's application or services or EHR, to primarily fit the needs of the patient. And whether that is providing remote care, whether it is having refills of medications, let's make it 90 days and have 3 refills so they're taken care of for a year. They on medical conditions in which are really stable. Rather than forcing them to jump through the hoops on having to call for another refill of, after a month or two. So again, a framework and focus and emphasis as far as what the patient's experience is in receiving and being taken care of. We may not be able to fix them. We may not be able to get them well. I wish it was an orthopedist. They are able to fix folks. But at least each and every time we should be able to take care of them or have them perceived that they felt taken care of.
Well, thank you, Dr. Jones. So Joshua, as someone who's, relatively new to your position, and I know now you have a much greater appreciation for James, probably going to take him out to lunch sometime next week, I'm sure. But, how do you feel you can take these lessons you've learned in the last month or so and use those as you move forward? And as Dr. Jones just talked about, look at ways to better take care of people as well as enhance and work with your physicians.
And I don't want to keep repeating myself, but I think just looking at how all the different avenues that we can approach patient care, if we can hit them with an in-office visit, a telemedicine visit, and just continue our continuity of care to retain those patients and just to have them feel like they receive the highest level of care possible, that they're happy to recommend us to any of their friends or family that run into similar orthopedic issues, or if they just know someone that has an orthopedic issue, that they look at our organization and they say, this is where you need to go. They take the time to really make sure that, you need to come here for this injury, that they are doing their due diligence to make sure that they're offering you exactly what you need and they're doing it at the highest level possible. And that they're, I just want to be the organization that patients feel that they're being well taken care of, that we're not cutting any corners, that we're giving them every avenue possible to make sure that they obtain the highest quality care. Just not here in Arkansas, but anywhere they can obtain care in the country.
Thank you. And I would like to just, as we wrap up here, I'd just like to thank each of you for your time today. I appreciate your insights, your commentary. As folks are listening to this webinar and have questions, I'd like to be able to help facilitate maybe additional conversations with folks who have specific questions. So if you're listening to this and you would like to reach out to any of our panelists, please contact me, and I will work to facilitate a conversation with whichever individual you'd like to speak with. But from the bottom of my heart, I appreciate each of your time today. Thank you very much, and we look forward to doing more of these in the future.
Thank you.